So today our patient is 60-year-old female with complaints of neurogenic claudication. Neurogenic claudication means patient is having more like numbness of both lower limb or leg, which gets aggravated by walking. And she doesn't have significant back pain. And this is the MRI of the patient. So in MRI you can identify these are all the bone. You can see this is L1 or lumbar number 1, number 2, number 3, number 4, number 5. So these are different numbers. This nomenclature is for identifying different vertebra. So you can see this is L4 or 4th lumbar vertebra, this is L5 or 5th lumbar vertebra. So there is compression here, some disc component and plamum hypertrophy also, which is causing compression of the 𝐻𝐤𝐤𝐿. You can see clearly here there is significant compression. On axial view you can see here, you can see this area, these are all normal area. Here nerve roots are free, rootlets are free, but here is severely compressed and these elements are compressing the nerve root. So here you can see this is thickened, this black color thing, this ligamentum flavum, it is thickened. Little bit thicker if you compare to the other area. You can compare with this area and the other segment also, this segment. So relatively it is thick and it is compressing the central part or 𝐻𝐤𝐤𝐿. So what we will do, we will operate with the help of endoscope. We will enter inside with the help of endoscope. We will take out all this thick ligamentum flavum, drill little bit bone here, so that the dural sac or nerve will get adequate space to expand, and hopefully patient will be symptom free after the surgery. So let's see what happens during surgery. So I will demonstrate you. So this is X-ray of the patient. This is AP view and lateral view of lumbar spine. So in lateral view you can see there is narrowing of the disc space and some degenerative changes. And in AP view also you can see there is curvature of the lumbar spine. Lumbar spine is little bit scoliotic or deformed. But however, patient doesn't have significant back pain and this bony symptoms. She is mainly complaining of neurogenic claudication, like she is having pain after pain and numbness, which gets aggravated after walking few steps, and because of the leg pain she is not able to walk more than 200 meters. That's why we are planning for decompression surgery only, and we will operate through endoscopic approach, interlaminar endoscopic approach. So we will enter inside through this narrow interlaminar window. This is the window. We will enter through this, and there is very little space. So we will drill little bit bone and enter inside with the scope, thin scope, and we will decompress all the compressing structure which is causing the symptoms, and hopefully patient will be symptom free immediately after surgery. And let's see what happens inside the surgery. So you can see there, this is the C-arm picture, this is the L4, L5 interlaminar window through which we will enter. So I will just do a stab incision here, you can focus here. So just a stab incision, then you can go inside. So I am cutting the fossa a little bit. We got the fossa as well. Now I will insert the dilator here. Okay. Okay. Yeah. So we are in the right space. So now lateral view. So this is just less than 1 centimeter incision size through which we are entering inside. Now, so after dilator I will insert this cannula. बड़ा करिया पड़े. Now on lateral view, we will confirm whether we are at the right level or not. So we will approach L4, L5 level. Okay, right? Foot? No. Foot? So you can take this view. So we are at the right level, L4, L5. Yeah. Done. So this instrument is known as endoscope. This is the camera attached here. So what is all the inside view I can see through this lens. So you can focus here. Lens is at the tip of the endoscope. Like this I can see all the inside view during surgery. Instrument. And there is a working channel also. So I can insert all the working instrument through this endoscope. So simultaneously I can see inside and I can operate. That's why it is monoportal endoscopic spine surgery, otherwise known as full endoscopic spine surgery. Monoport means single incision, single port, single entry, and you can operate through this endoscope work with which has working channel associated with it. In biportal, there are basically two equipment. One is scope, other is the working instrument. So they have to do two incision for this. But here we operate through single incision. That's why it's monoportal surgery, and it is relatively less invasive than the biportal surgery. Water, and this is a water medium surgery. So you can see, yeah, water is coming out, which will create a good view. So we don't need to suck again and again. So this is the inside view. There are a few muscles. And just little bit focus the camera. Yeah, it's a good view. So this is the base of the spinous process I have identified. This is the lamina going like this. So inferior articular process will be here. So we'll start drilling from the base of the spinous process and we'll go down like this. So we'll start drilling. I will start drilling from the base of the spinous process, going down like this. I am drilling the lamina here. This is the base of the spinous process. I am drilling central part. Okay. Bipolar. A little bit clear now. So I am rotating the scope. This base of the spinous process, this is the lamina. It goes like this. So here will be the inferior articular process. I can palpate it. So I will remove little bit soft tissue here. So it will be easy, so that this soft tissue won't entangle the drill or the burr we are using. Okay. So our goal should be as less as soft tissue we remove from or around the facet joint. So this is now you can identify clearly it is going down. This is the bone. This is the inferior articular process. So joint will be here. Okay. So here is the tip of the inferior articular process. Here is the joint. I will show you within a minute. Bipolar joint. So you can see. Okay. So this is the inferior articular process. Here will be the joint. I will remove a little bit of soft tissue from this area so that you can see easily. Cut up. Okay. Anatomy is a little bit clear. We'll start drilling. So I'll do sublaminar drilling of the opposite side also. So this is the contralateral drilling I am doing. So this is the center, this is the ipsilateral side, and this is the contralateral side I am doing. sublaminar building. Okay. Okay. You can see this is the center, this is the ipsilateral side, this is the contralateral side. Okay. So these are contralateral joints here. The contralateral lamina. We have made this V into U. You can see the nice U. So this is the apex of the U. Here is the inferior articular process. Here will be the joint. I will go down a little later. So, I am taking out the superficial layer of the ligamentum flavum. Yellow annulita. From its upper border, you can see this is the upper attachment of ligamentum flavum, and this is the midline. You can see. So this is the lower lamina, upper border of the lower lamina. I will drill it a little bit, then remove all this. This is the upper border of the lower lamina. Press. So I am doing contralateral lateral recess decompression. This is the opposite side. I am retracting the root and taking out the deep layer of the ligamentum flavum. So I have completed the surgery. So for your orientation, this is cranial end, this is caudal end, this is ipsilateral side, left side of the patient, this is contralateral side. So this is the thecal sac or central dura, which is free. It is swollen, you can see. So this is the root. I can retract it gently. You can see it is free. This is the disc face. This is the contralateral opposite side. This is the opposite side root coming out here. This side also free. This is the contralateral disc. So hopefully the patient will be completely symptom free. So now I am coming out. I will control a little bit of bleeding. There is no bleeding. So I will control a little of bleeding from this muscle. Press. Okay. 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 Bara? Okay. So you can see size of the incision. Okay. How small it is. Now you have watched the procedure of endoscopic surgery. So let's see how the patient respond to the surgery. So one advantage of the surgery is we can mobilize the patient early. So let's see, let's go to the bedside and see how patient is responding to the surgery.